Good afternoon, everyone, and thank you for joining us today. My name is Dimitri Beekman. I'm a professor of skin integrity and clinical nursing at Ghent University in Belgium and at Örebro University in Sweden. I hold several professorships at various European universities, and currently I'm a member of the Council of the European Wound Management Association, and I also serve as the president of the International Skin Care Advisory Panel. And together with my colleague, Salvacion Cruz, I will moderate this webinar today. Would you like to introduce yourself, Salvacion? Salvacion, your mic is on mute.
Sorry for that. Thank you, Dimitri, and good afternoon, everyone, and thank you for joining us. So my name is Salvacion Cruz. I am currently working as a wound care nurse at Sheikh Khalifa Medical City here in Abu Dhabi, where I have been working since 2005. I am currently served as the Regional Director of ISTAP in the Middle East. So hope you will enjoy this webinar for today.
Thank you very much, Salvacion. So this webinar is the final one in a two-part series focusing on various aspects of skin tear prevention and treatment under the title, The Science and Practice of Skin Tears. Today's webinar will be recorded, so you will be able to watch the webinar on demand. The recording will be available via the websites of EWMA and ISTAP within a few days. Today we've got 5 speakers, and our 5 speakers will each have 15 minutes for their presentation. Please note, as this is an interactive session, you will have the opportunity to provide questions in the Q&A box anytime during the lecture. So feel free to write the questions in either your native language or in English. Today's speakers will address as many questions as we can in the Q&A session that will conclude this webinar. And then I give the word to Salvacion. She will mention something about our sponsors.
Before we begin this webinar, we would like to give thanks to our sponsors, the Monolike and Essity, who kindly supported the Skin Tears Prevention campaign and this webinar series. The supporting companies have not had any influence on the content of this webinar. Back to you, Dimitri.
Thank you very much, Salvacion. I'm now pleased to introduce the presentations and welcome the speakers of today. So our speakers of this webinar, they are presented on the screen, and they are Professor Karen Usi, who will be speaking on the control of infection in skin tears. Dr. Kimberly LeBlanc, who will talk about the protection of the peri-wound area. Mr. Steven Smets, who will be talking about the knowledge translation into practice, so practice tips for using this ISTAP skin tear algorithm in daily practice, some case discussions. Then Kerstin Protz will provide insight on the knowledge translation into practice 2, about the disseminating of best practices, the German experience. And then Ms. Annika Furi, she will be speaking on the prone text practice guidance document, skin care considerations for the patient in the prone position. And now our first presentation by Professor Karen Usi, who will talk about the control of infection in skin tears. Thank you very much. Enjoy the webinar.
Hello, everyone, and thank you for joining this session, Control of Infection in Skin Tears. I'm Karen Uzi. I'm Professor of Skin Integrity at the University of Huddersfield in the UK, and I'm also European Director of the International Skin Tears Advisory Panel. And I'm absolutely delighted to be presenting this subject to you today. So before we start, I've got no conflicts of interest to declare related to this presentation. But what is a skin tear? And I know you've heard it before, but I always think it's good just to review the definition. So according to LeBlanc et al., it's a traumatic wound caused by mechanical forces, including removal of adhesives. And remember, severity may vary depending on the depth, but the skin tears do not extend through the subcutaneous layer. And you can see here on the screen 2 images of skin tears. We've got the traditional skin tear that many people think about, which is to the bottom of the arm. but we've also got a more severe one that's on the lower limb, but both of them are skin tears. And there are 3 different types of skin tears, and the International Skin Tears Advisory Panel have produced a skin tear classification that people can look at, very easy to see. So type 1 is no skin loss, type 2 is partial flap loss, and type 3 is total flap loss. But as you can see, all of those skin tears are at potential risk of developing an infection, which is why it's so important that we understand what an infection is, how we can identify it at an early stage, and unfortunately the patient does develop an infection, how we manage it. So what is an infection? Well, we know that wounds by their nature are caused by a break in the skin. So any break in the skin is classed as a wound, however small or however large. And the integrity of the skin prevents egress of bodily components such as your blood, etc., but also ingress of foreign matter that can damage the body, which includes bacteria, which can obviously lead to an infection. And we know it's the invasion of the wound by proliferating microorganisms that invoke this local spreading or systemic response. So we have an infection trajectory, if you like, from very mild to very serious, and we're going to look at that very shortly. But these microorganisms multiply within a wound, developing a range of virulence factors that overcome our body's host defences, and that's what leads to this local tissue damage and impedes wound healing, thereby preventing the normal wound healing trajectory occur, which can obviously lead to excessive pain for the patient, excess nurse visits to the home if the patient's at home, or an increased stay in hospital. And no patient wants that at all. So it's important that we have a clear assessment of the wound and the patient to try and prevent infection. And ISTAP has produced this risk reduction programme that I suggest that everybody may want to go and have a look at. So it very much looks at not just the skin tear, but looks at the skin, mobility needs of the patient, and general health as well. Because when we go and look at patients with wounds or skin tears, then we shouldn't just be looking at the wound itself. We should be doing a holistic assessment of the patient. So look at the skin. Have they got history of any skin tears? What does the skin look like? Is it dry? Is it fragile? Have we got any increased extremes of age? So is the patient very young or the patient very old? We also need to look at the mobility status of the patient. How active are they? What's their physical function like? Do they tend to knock into things a lot? So what's their eyesight like as well? Because sometimes it's just a matter of ensuring the patient can see properly to stop them bumping into furniture, for example, that can cause damage to the skin. And what's general health like? And do patients and carers understand about general health as well to help that person who maybe has a skin tear? But the International Wound Infection Institute produced their 2016 consensus document on early identification, prevention and management of wound infection. This has been updated, and the 2020 consensus document is now available to freely download from the International Wound Infection Institute's website. But within that, there's this really nice assessment tool here that's based on the word wound and taken from Nikki Waters' previous work. And it talks about W, think about what has happened to the person, what's their past history and what's caused that wound. So who, what, where, when and why. The O is for oxygen perfusion. So assess factors that can impact that tissue perfusion. So look at fluid management of the patient, PO2 levels, the temperature, stress, and any sort of activities of daily living that they've been involved in. Leading on to underlying factors. So remember, it's not just about the wound itself, it's about looking at the patient holistically. So assess any factors related to a potential infection risk. Again, extremes of age and mobility, as ISTAP told us to look at as well in their risk management programme. Look at psychosocial issues, look at the continence status of the patient as well, and how well are they? Can they manage to self-care themselves or do they need help? N is for nutrition. And we know nutrition is essential in all wound healing. That's no different for skin tears either. So we need to be ensuring we're conducting nutritional screening for all these patients and refer on to dietitians if needed. Also give advice to the patient and their family and carers about what good nutrition is as well. And then look at underlying conditions. So this is D for disease and drugs. So we must ensure that we assess any comorbidities. Does the patient have a long-term condition, for example, diabetes, that may affect the fragility of the skin? Also look at if they're immunocompromised, or is there any steroid use? Because this can all add to the skin and can make the skin more fragile. So it's essential that we undertake these assessments regularly, appropriately, in a timely fashion. And also remember to document all your assessments as well. Because when we go and see patients with skin tears or any type of wound, it's not very often that the same person will go back and reassess the patient. So they won't know what you've assessed and what your rationale is for choosing various different dressings or your plan of care. So ensure it's written down, documented clearly, so that next person can follow your plan of care and make changes if appropriate. But how do we diagnose an infection? Well, we need to look at the wound etiology, what's caused it, what's underlying it. Again, the age of the person, any comorbidities and any medications. And remember to document all of these. But I must stress that all open wounds are contaminated or colonized with microorganisms. This doesn't mean they're all going to become infected. And remember, we're all contaminated and colonized with some microorganism, but we don't have an infection. So it's important that we understand how to assess for any classical signs of wound infection, including any excessive heat around that wound, any pain, any pyrexia, or the patient saying that they feel generally unwell. And we'll look at this in more detail very shortly. But assessment and diagnosis in a timely fashion is so important. And when we look at these two images of skin tears, are they inflamed, are they infected? Sometimes we find that people get a little bit confused with what's inflammation and what's infection. So when you look at these, you may think, oh, I'm not really sure, because they're both quite red and the skin looks quite damaged on both of them. If you look at the left one, it does look red, yes. The skin tear itself looks red and the peri-wound area looks red, but that's inflammation. That's a normal inflammatory process. The patient's feeling well, not complaining of any excessive pain. Therefore, that skin tear is inflamed. So there's no need to use antimicrobial wound dressings or to administer antibiotics because there's no sign of infection. Whereas the image on the right, you can clearly see, looks very red, looks very inflamed, and there's signs of exudate there as well. And the patient is pyrexial and complaining of excessive pain. But you may think, how do I remember all of this? Well, again, the International Wound Infection Institute's document provides this really handy table that shows you the different stages on the wound infection continuum. So we have contamination, colonization. That's where there's no signs of infection at all, so we don't need to worry, but we do need to keep assessing the wound. We've then got local infection, and we need to be aware of the covert and overt signs, any signs of hypergranulation, bleeding, wound breakdown, or increasing pain and increasing malodor. Then we need to be thinking about antimicrobials and taking wound swabs, for example. The patient may have spreading infection. They have that, you'll see that there's a greater degree of wound breakdown and dehiscence. Patient will complain of lethargy. They'll have a loss of appetite, and there could well be inflammation and swelling of the lymph glands. If there's systemic infection, this is an emergency because we're at risk of severe sepsis, septic shock, and death. So it's important that we're able to look at this continuum and understand the very different signs and symptoms and what we really need to be aware of. But you may want to cleanse your wound to have a proper look at what's going on that wound bed. And we need to assess the wound. And again, think about the etiology, where the location is, and any visible structures. Is the person at risk of wound infection? So you've done your assessment, you know about the comorbidities, you know which medications the patient's on, and if they've got a past history of wound infection as well. So you already know about that. Think about your goals of care as well. What do you want to achieve when you're cleaning the wound? And what do your local policies and resources say? And what sorts of cleansing solutions are you able to access? Not everybody can access all the same cleansers, so please make sure you look at what your local guidance is saying. And there's a range of different cleansers. There's normal tap water, that as long as that water is clean, you can use that if that's all you can get hold of, or you may want to boil it and then let it cool down. You may be able to access sterile normal saline or sterile water. And sometimes we may want to use surfactants, and that's when the wound needs a greater mechanical action for cleansing because maybe there's a biofilm present there. Once you've cleansed the wound, then you may want to take a specimen, and there's different ways of taking a specimen. Maybe tissue biopsy, wound fluid aspirate, you may wish to debride tissue using short debridement, or you may want to take a wound swab. And generally people take wound swabs. But please remember that the Levine technique is the technique that we suggest you use. Again, the International Wound Infection Institute talks about this and describes it quite nicely in their consensus document. And there's various different YouTube videos that explain what the Levine technique is and how to undertake it. So please do have a look and use this instead of the said technique. But also remember, you must clean the wound first prior to taking a wound swab. We want to be taking it off a relatively clean wound bed. Once you clean the wound and you've decided that which dressings you want to put on, then you need to go back and evaluate it regularly and decide whether or not there's any improvement or deterioration within that wound bed itself. So, is there an increased amount of granulation tissue around the skin tear? If there is, then we can think, yes, this is beginning to heal quite nicely. But if we have increased levels of exudate and we've got maceration and swelling around the peri-wound skin, then we're going to consider that wound is deteriorating. And we'll want to think about, are we using the correct dressing? Do we need antibiotics? Is there an increase in malodor as well? If there is, again, suspect infection, take your wound swab and use your antimicrobials. So remember to always evaluate, again, document what your evaluations say. The wound is infected, then we do need to use antimicrobial strategies. So using antiseptics, antibiotics, and antimicrobial wound dressings. If there's no signs of infection, then we don't need to be using antimicrobials. And this is so important because of this increasing risk of antimicrobial resistance. And this is where we have these superbugs, and they're resistant to all our antimicrobials. And this has actually come around because of misuse of medicines in the past and poor infection control practices. And it does affect wound management. So please ensure that you're only using them if the wound is actually infected. And this is why we should be concerned, because for 30 years it's been since we've had a new antibiotic developed. So we need to have judicious use of the antimicrobials that we have at the moment. So when trying to control infections in skin tears, remember, holistic assessment of the patient, holistic assessment of the wound itself, decide whether or not it's infected or inflamed, and manage it as appropriate. If you want any more information, please have a look at all these wonderful resources that are being produced by ISTAP as well. Thank you very much for listening, and I look forward to answering any questions.
Hi, my name is Kimberly LeBlanc, and I am the Academic Chair for Nurses Specialized in Wound, Ostomy, and Continence Canada, and I serve on the Board of Directors for the International Skin Tear Advisory Panel. And it's my pleasure to speak to you today about a topic that's near and dear to my heart, which is peri-wound skin complications. Before I begin, I would like to read a Truth and Reconciliation Statement in recognition of the Algonquin territory. I recognize that I am presenting from the unceded territory of the Algonquin Anishinaabe Nation. I extend my respect to all First Nations, Inuit, and Métis peoples for their valuable past and present contributions to this land. I recognize and respect the cultural, diversity that First Nations, Inuit, and Métis people bring to the city of Ottawa and to Canada. These are my conflicts of interest. So by the end of this session, I would like the learner, those of you watching, to be able to define the Periwin skin complications, to discuss the importance of Periwin skin integrity, describe the risk factors for Periwin skin complications, and to talk about the ISTAP consensus statements. So you can find everything I'm going to tell you about today on the Wounds International website, which is www.woundsinternational.com. And you can download these best practice recommendations for the prevention and management of periwound skin complications free of charge. So let's start by defining the periwound, and because that's something that a lot of people get confused about. Like, what is the what do we consider the periwound? Is it 2 centimeters? Is it 4 centimeters? So part of our consensus was we said that the periwound skin is that area around the wound that may be negatively affected by wound-related factors and underlying pathology. So if we look at this wound here, we would consider the area that's highlighted to be the periwound area. So why is the periwound skin important? Well, we know that periwound skin damage is a risk factor for delayed wound healing, and that's something that none of us want to see happen. But what we see is that damage to the periwound can actually contribute to delayed wound healing, wound deterioration, pain and discomfort, and reduced patient quality of life. And one of the things that my patients will tell me, and many of you probably have seen this as well, is that patients will tell you that when their dressing becomes saturated or the wound becomes macerated and the wound edges become macerated, that they start having this burning pain, both in their wound and the skin around the wound. We know that not all periwound skin damage is avoidable, and I do think it's important that we recognize that. But that doesn't mean that we should stop striving to mitigate it and minimize the damage. We know that periwound skin is particularly vulnerable to moisture, and so we need to think about moisture-associated skin damage in the periwound area, so that we can really make sure that we're mitigating, we're minimizing that issue, that we're preventing that erosion that can occur related to wound exudate. And we know that when we have exposure to abnormal levels of matrix metalloproteases or MMPs, that this can cause damage in the wound bed itself, but as well to that periwound area, and it damages that epidermal barrier function. Another concept that is near and dear to my heart is the concept that was first coined by Laurie McNichol and her group, and that's medical adhesive-related skin injury, or MARSI. And we look at MARSI, we know that it's often related to adhesive tapes that strip away the periwound stratum corneum area. And so what we'll see is that, we'll often have skin tears that develop or tension blisters. Those type of injuries will occur. And we know that it can occur in all patient groups, but those at the extremes of age are more susceptible, or those with specific skin conditions or comorbidities. So we also know, as I talked before, about maceration or moisture-associated skin damage. So the skin surrounding the wound is particularly susceptible for injuries, even though it may appear healthy. And part of that reason is that repeat exposure. So we may see skin damage that can adversely affect, as we said before, your patient's quality of life and that increased pain and discomfort. And that we need to know the key factors that can aggravate the susceptibility to the skin surrounding a wound and how we can prevent and manage those issues. So we need to look at doing our wound assessment. That's really important so that we know what is happening with our patient and how can we manage those factors. So we need to know the cause of the wound, the location, the duration, the dimensions, the wound bed characteristics, type and amount of exudate. Is there bleeding? Is there a hematoma? Signs and symptoms of infection, pain, and the integrity of the periwound skin. So I challenge you to make sure that you're documenting what that periwound skin looks like at each dressing change. Now, one of the things that I'm really interested in is this whole concept of what we can modify and what we can't modify. And often we're looking at wounds, there's all kinds of factors that we can't modify or change, or any other health conditions. But when it comes to the peri-wound skin, you'll notice that each one of these risk factors is actually modifiable to a certain degree. So types of medications we're using and how we actually interact with those medications. While some of these factors are intrinsic or extrinsic, they have it all in common that we can modify them to some degree. So xerosis or dry skin, other skin conditions such as dermatitis, psoriasis, or scleroderma, we may not be able to change the intrinsic nature of them, but we can certainly modify them and mitigate the body's response to a certain degree. Patient-related factors such as host response or skin flora. Someone may have be colonized with candidata, for example. Patient environment, skin hygiene, mechanical skin injury, so that's that medical adhesive-related skin injury, the type of adhesive dressings that we're using. We can make a difference here. These are things that we can actually intervene and choose the best products for our patient at that given time. Here's some more risk factors, and you can see once again, these are all modifiable for the most part. So frequency of dressing changes, types of dressings we're using, how we manage the amount of wound exudate, the microclimate or moisture, allergens or irritants that we're using on the skin. Now, skin frailty is an intrinsic characteristic that we have. And for the most part, we can't modify it. However, what we can modify is how we actually manage that fragile skin. So for instance, Dr. Carville and her team discovered that we could reduce the risk of skin tears by moisturizing the skin twice daily. And that by doing so, we can decrease the incidence by almost 50%. So if we transfer that type of knowledge to the peri-wound, and if we have fragile skin in the peri-wound area, then we could look at, do we need to be moisturizing that skin? And what moistures can we use that won't interfere with dressings? We need to look at patient's concordance. So what dressings we choose and how often we change the dressings, how does that affect our patient's lifestyle? And how can we make sure that our patients are collaborating with us? And what social factors and access to healthcare issues do we need to look at? So let's talk a little bit about protecting the peri-wound skin. So we need to look at our peri-wound skin, we need to assess it, and then we need to look at selecting skin barriers with absorptive properties. Do we need to apply a liquid film barrier such as a cyanacrylate? We want to make sure we're not using creams or ointments that are going to interfere with dressing adhesion. We want to make sure that we're using a large enough dressing. We need to look at, do we need to use antimicrobial cleansing of the skin? Do we have folliculitis present? We need to avoid frequent dressing changes, but we need to find that balancing act between making sure we have an absorptive enough dressing that we can leave on for a long enough period of time, but changing it when we start to get saturation level. And that's going to be dependent on local wound factors. We may want to consider topical steroids for hypersensitive responses. We may want to consider the use of a non-adhesive dressings or dressings without borders and using tubular retention bandages in some cases. We should always look to use the lowest level of adhesive products possible. Now, there's going to be times when we have to use high level of adhesion, depending on the type of wound, its location, and the reason that the dressing is in place. But we need to make sure these are patient specific, that we look at each individual case, and that we use the lowest level of adhesive products as possible. And when possible, we should also look at rotating where we affix the tape or adhesive so that we can avoid repeat trauma to an area. And we want to avoid applying any tension when we put the dressings on so we can avoid those tension blisters. Now, there's different types of adhesives. So we know that those rubber-based adhesives, we really don't use those very much anymore. The practice use is declining, at least in North America, but it's still available, and there are times when we still need it. We're seeing acrylic-based adhesives used more and more. They're very common in dressings, but we know that they can be traumatic to vulnerable skin, but there's times we can't avoid using them. And we know that the silicone-based adhesives really provide minimal risk for trauma. However, there's times when we need stronger adhesion. So we need to keep those factors in mind. We want to make sure that we're protecting that periwound skin from damage from moisture. And one of the things I'll challenge you with is if you get a patient that you're really not managing that periwound skin and you're getting a lot of moisture and problems with adhesion, one thing that you can do is, if you're not a stoma care nurse, a WOCN or an NSWAC or an ET nurse, you may want to find one of us who can help you, because often in my practice, I draw on my knowledge as an ostomy nurse to help with my wound care nurse side of me. So I will often bring in things such as picture framing methods. I'll use stoma powder and different methods that we use with peristomal areas to help protect that periwound skin and manage the excess moisture. So we also want to make sure that we're looking at the absorptive properties and that we're using a dressing that's absorptive enough. We may have to look at layering products. We may need secondary pads. Sometimes we leave the base pad in place and we're changing the outer pads. But it's really important that we try to use a combination that's going to minimize dressing changes, but will always absorb the excess moisture, and that it won't cause increased trauma on removal. We use a lot of liquid barrier films, such as cyanacrylates, to protect the periwound skin. We want to, as we said before, avoid creams or ointments that can interfere with dressing adhesion. And dressing change frequency should really be based on the type and amount of wound exudate. Remove dressings in the direction of hair growth. And once again, this comes back to talk to a stoma care nurse if you're not one yourself, to get some of the tips and tricks we use for managing hair growth under ostomy appliances, because this can be directly applied to the periwound as well. For instance, we remove hair, when we're removing hair, we clip it rather than doing a close shave. We try to make sure that we are shaving, that we're going in the direction of the hair growth. So I wanted to quickly go over the consensus statements themselves, and you've seen them interspersed throughout my presentation. But really, we want to look at periwound damage as a risk factor for delayed wound healing, can increase the risk of infection. Healthcare professionals, caregivers, and individuals should manage modifiable intrinsic, extrinsic factors. We know that not all periwound damage is avoidable. Exudate management is the key to avoiding periwound damage. If someone has a disruption in skin integrity, we need to make sure that we take that detailed history of the individual's health status with a particular focus on the periwound skin. And that structured wound assessment should always include, what does the integrity of the periwound look like? We need to make sure that we're implementing best available evidence for the prevention and treatment of periwound complications, knowing that the wound care knowledge is evolving very quickly. So we need to stay up to date so that we know what is the current best evidence. We need to make sure that we're assessing the periwound at each dressing change, planning management according to the risk factors identified. All interventions to manage infection or infection risk should take an approach that follows antimicrobial stewardship principles. That we need to collaborate with a specialist if periwound damage is complex or beyond your knowledge and skill, or persists despite best practice interventions. And remember, this is where I think collaboration with a stoma care nurse can actually really help you with the management of that periwound skin, just because of the breadth of experience that stoma care nurses have with caring for peristomal maceration or medical adhesive related skin injury. So depending on where you are in the world depends on what you call us. So in North America, you're either a wound ostomy incontinence nurse or a nurse specialized in wound ostomy incontinence. In other areas of the world, you may be called an interstomal therapist or a stoma care nurse. We want to make sure that we're educating people on periwound skin and how we need to make sure that it's integrated into existing wound education programs. And we need research to address gaps in the literature and to inform evidence-based practice. So with that, I thank you for your attention. I hope I've given you some pearls that you can take back to your practice, and I look forward to your questions.
Hello, I'm Steven Smets. I'm a clinical nurse specialist of wound care in Ghent University Hospital, and I'm also a PhD candidate within the Skin Integrity Research Group. I will tell you a bit more about practice tips for using the ISTAP skin tear algorithm in daily practice. First of all, I can already say that I have no conflict of interest related to the topic of the presentation. Now, I will not start immediately with presenting cases where I use the skin tear algorithm. I think it's always very important first, like, yeah, why do we use this algorithm or this procedure? Is there a current problem? And I think then if we focus on the skin tears, we know that there are quite much different figures, that there's much variety in the figures. We know in long-term care that it goes from 2% till 92%. If we focus to the acute care, I'm working in a hospital, for example, we have figures between 6 and 11%. And if you then look to recent publications, I found one, for example, from Kim LeBlanc and her colleagues, where they checked the prevalence and incidence rates in a long-term care facility in Ontario. And there they had skin tear prevalence rates of 20.8% and incidence rates of almost 19%. So it confirms that the rates are high and that there's still a problem present. If we then focus a bit more on the acute care setting, I found an interesting publication where they checked the prevalence for 10 years in an Australian acute care hospital. And when they analyzed the figures, they saw that the pooled prevalence rates were around 9%, with rates of associated hospital-acquired prevalence around 5.5%. Also interesting to see was that over a third of the patients had more than one skin tear. Most patients were more than 70 years or older than 70 years, what was quite what you could expect, of course. And also what they saw was that the largest proportion of skin tears were the category 3 ones, where there was no skin flap remained. If you go a bit more into detail, it was also good to see that over time the prevalence rates went down. So by measuring, putting attention on the fact that skin tears occur, it had a positive effect, especially the hospital-acquired rate went down over time. And if you look to the location of the skin tears, we saw that there was more or less an equal distribution between the upper limb and the lower limb. And when you focus on the lower limb, the biggest proportion of skin tears occurred at the lower leg. So is there a problem? Yeah, I think there is a problem. And we know that the prevalence rates will still increase because we know that the highest risk groups are the older patients with a vulnerable age skin, and this patient group will increase. So yeah, there's a problem and we have to do something about it. And what can we do about it? We know already that there's a skin tear risk assessment. So the best practice recommendation document helps you with this. And we know there are 3 big risk categories: the skin, the mobility of the patient, and the general health. And by putting attention to some action points, by improving the skin condition and hydration of the skin, optimizing the mobility of the patient, optimizing nutrition and hydration of the patient, we know that by that we can also lower the amount of skin tears. How do we do that mostly? Well, many people work with skin tear bundles, and I was very happy to see that there's a very recent publication, a systematic review, where they checked these skin tear bundles or these prevention procedures, and they identified that there was a direct relationship between the use of these skin care bundles and the reduction in the incidence of skin tears in the elderly. The validity of the included studies was quite okay. And so we can conclude that further studies regarding these skin tear bundles is certainly justified and necessary, and that they really help in preventing skin tears. And not only skin tears, also the related problems, as a skin tear can evolve into a chronic wound or can evolve into an infection. All these things will also be prevented if we prevent the development of skin tears. And yeah, you have the details of these studies. It was good to see that many different protocols and procedures were used and that they all had a positive effect. Another nice example is where they empowered the residential care home staff in the UK to prevent that the needs from specific specialized district nurses were necessary to treat the skin tears. And what did they see at the end of the project? That 93% of all skin tears could be managed by the residential care staff, so that they didn't need anymore the district nurses to treat these skin tears. And this project is now rolled out to all care home services across the South Warwickshire Foundation Trust. It's also something interesting to check. So yeah, we know that prevention works, but yeah, sometimes skin tears develop. And what do we do then with these skin tears? For that, we have the skin tear decision algorithm, which is quite straightforward. I think you have a skin tear, you assess it, you control the bleeding, you cleanse, you approximate the wound itches as much as possible, and afterwards the remaining wounds, you follow the principles of moist wound healing, you avoid further trauma, you classify, and you report this in your patient file and go further with the treatment. But yeah, of course, this is like the goals of treatment, but what products can we use then? In the article there where they followed up on the 10 years prevalence in an acute care setting, I found a small chapter related to the wound dressings, and they said there that most skin tears were protected with a foam dressing. A small proportion was not dressed, and 2 wounds were found where they used fixation tapes only. Now, is that the correct way that you would say, because you have foam dressings on most of the skin tears? Well, you see here the product selection guide that is also published, that there are many options, and it will really depend on the type of skin tear and also of the wound bed, which product you will use. Specifically, it's important that you follow the rules of an ideal dressing and that you control bleeding, that's atraumatic, that you optimize the wound bed condition, that you can follow the rules of moist wound healing and so on. But of course, yeah, you have many suggestions, and still people use also products that are not on these product selection guides. And how come? And then it was a bit remarkable that also in recent publications, I found, for example, this example, it's more case discussions that are published, but here it was a publication about grafts that they used on the wound bed of skin tears. But of course, then they approximate the wound edges again with those adhesive straps. We also call them butterfly stitches. And of course, yeah, this can be very traumatic for the surrounding skin and can create new skin tears. But this was published in the journal, in a journal for the emergency medicine. So of course, yeah, people will see these publications and it can cause confusion, of course. Even a much more recent publication, it's about the device, which looks very similar to butterfly stitches. I don't know the device, I'm honest about this, and maybe it's a good solution, but of course it's very similar than butterfly stitches, and I can imagine it causes confusion about which is the right therapy. Now in our hospital, we only have since 2021 also a hospital-wide protocol. Before that, we only had a protocol on the emergency care department. And it's not that we don't put attention on skin tears, but we always thought like, yeah, we know how to treat it. It's not so difficult. We don't have big problems. We could extract the figures from our files, but until now we didn't do it. And we have many protocols. And of course, yeah, we also need then a protocol for skin tears. It's quite logic, but I think many institutions have maybe the same attitude that we had also for a long time. But you have the theory, of course, and you have the clinical practice. And despite that we have a protocol on the emergency care department, we saw, for example, this case where they used a lot of butterfly stitches and I needed half an hour to remove them all very carefully to not create more skin tears. Other examples where they use still the butterfly stitches, they reposition the skin flap as it should be, but here it was still the bleeding that was not stopped. And you see on the left picture that a new hematoma was developing under the skin flap. On the right situation, again, butterfly stitches that were used here also. And then you think, yeah, finally they start working with the silicone contact layers, but then, yeah, they start combining these products, which is of course, and again, not the most optimal treatment, or totally not the optimal treatment. And if you see then this, of course, then you know there's still a lot of work to do. Here they used staples in combination with a silicone contact layer. And here we had a complicated wound healing process also. But of course, there are also many good cases. And we had here a patient with the Wegener disease. So she already needed for a long time corticosteroid medication. She had a confirmed allergy for povidone iodine, and she was admitted in our hospital for severe abdominal pain and diarrhea. She developed 2 extensive skin tears because she fell and her husband tried to hold her arm while she was falling. And we had 2 very extensive skin tears on the right elbow and the right lower arm. If we focus on the elbow, you see that we could still reposition a part of the skin flap. For the lower arm, the skin flap was completely lost. You still see a little bit of remaining skin flap there on the right button, but this was not viable anymore. If we focus on the elbow, so what did we do? Control bleeding. That was done quite easily. An extensive silicone contact layer we put on top, compresses on top of that. And the silicone contact layer we always keep in place for 7 days to really have no trauma to the wound flap. But the compresses we change daily, and on top of the silicone contact layer, we cleanse daily also. Here you see that it's important to really place an extensive silicone contact layer on the wound beds. The lower arm here, so you can see we had quite extensive bleeding. So we had to use even local adrenaline to stop the bleeding. The remaining skin flap was not viable, and we also didn't want to reposition it to prevent the development of an hematoma. But for the rest, we used the same principles as with the elbow. But what did we see after 2 days? That there was more, some odor, there was more fibrinous tissue present. So we started with honey to treat this, and combined with that, we changed anyhow then the silicone contact layer twice, every 3 days, to have a more regular, thorough cleansing of the wound beds. What did we see after a week? That on the elbow, the skin flap was very well adhered to the wound bed, almost 80%. So we went further with our therapy. But if we focus to the lower arm, we saw that it stayed a bit status quo. As there was no wound flap remained anymore, we started here now with a daily wound dressing. So we combined the honey ointment with the paraffin gauze dressing to have an atraumatic removal of the dressing, but that we daily could very well cleanse the wound and also following the principles of an osmotic wound debridement. As you can see, the 9th of 11, the elbow was completely healed. Residual lesions were treated with a foam dressing, and the intact skin was moisturized daily by a lipophilic hydrating cream. On the lower arm, we saw slow epithelial tissue developing, less exudate, so we had a positive evolution, so we went further with the honey ointment here. And as you can see, the 16th of November, the wound was completely healed. Afterwards, we had, of course, to follow the preventive measures, preventive padding, use of bed rail protectors, and also use specific clothing to prevent new skin tear development. And as you can see, this is an example. Sometimes you have really extensive skin tears, but where you can reposition still quite well the skin flap. And these wounds also could heal conservatively. We didn't need here any surgery. Just by silicone contact layers, we could heal these wounds. But of course, it's not always the case. Here we had an hematoma that developed under the skin flap, and this had to be removed and became a chronic wound that healed by secondary intention. And as a last example, be always critical also when they tell you, yeah, there's a skin tear, is it IAD, is it a pressure ulcer? Here you have often combinations of trauma. And if you see on the picture on the right, here they said, yeah, this is a pressure ulcer or an IAD. But at the end, this was more trauma because you saw older traumatic lesions of adhesive bandages, and probably here was also a trauma, but this wound didn't heal well and became then more chronic. So often you have combinations. Also here, this was a patient that was very allergic to the bandages, and this was an allergic reaction, had nothing to do with a skin tear. So also asked for a different treatment. And here on the leg, they also diagnosed this as a skin tear, but of course, this was really an eczema at the leg, probably started with a trauma, but then an allergic reaction occurred. So yeah, the use of a protocol skin tear algorithm is keen to evolve into good clinical practice, but of course, make sure you have the right diagnose. Also then, if you have a protocol, keep in mind the motivation of the healthcare givers to follow the protocol. How do you do that? Track prevalence incidents, educate, and certainly also follow up on the outcomes. I thank you very much for your attention.
Hearty moin from Hamburg, Germany to everybody. It's a great pleasure and honor for me to tell you something about the German experience according to skin tears. First of all, let us have a look at the content of my presentation. I will tell you something about our awareness problem, our risk management, and the therapy options. First of all, we have a very huge challenge to fight in Germany. We have to create awareness for the identification of skin tears. I do a lot of teaching work and so-called wound expert courses all over Germany. And when I ask my participants, what do you know about skin tears? Then they look at me like a question mark or something like this and say, what do you mean? I have never heard such a term or this wording. When I show them photographs, as you can see here, then they say, ah, you mean a little scratch or a small rupture? That's nothing. A laceration, an erosion, some say a pressure ulcer stage 2, but this is very poor outcome. So these wounds are very often underestimated as minor wounds and often not even recorded or documented because most of the participants say that's not worth the effort. And so the patient suffers not only a lot of pain, he gets no treatment and a lot of complication. There we have to start. We know that approximately every 10th resident in elderly care or patients in hospital that are over 65 years old are affected. And we have another problem because skin tears are in many cases not correctly diagnosed, for example, as a pressure ulcer stage 2. And we know these wounds are completely treated in another way than skin tears. And in Germany, our physicians have the responsibility for diagnosis and for treatment. And there starts another problem because in their medical education, they learn nothing about wounds or wound treatment. And so this altogether shows the fundament for this topic is not laid in Germany. So we have to start at the very, very beginning. This is a long way to go. Additionally, we have to know something about risk management. How can we minimize the risk for skin tears? First of all, we need information for all healthcare providers about the risk and prevention options of skin tears. And healthcare providers means physicians and nurses as well. And of course, we have to involve our patients and their relatives in the care process because otherwise we couldn't work together. And this would influence the adherence and quality of life of our patients. And this shouldn't work in practice. Everyone is talking above the head of the patient, but not with him, so he couldn't work with us together. First of all, we have to minimize the risk for the skin because the skin is one of the most important factors here. And we know especially the elderly skin is very thin, it's fragile, it's dry, and it needs help and special care. Optimal are products that are based on water and oil emulsions with additional moisturizing factors. In Germany, urea is very common, but we see sometimes skin problems as well. So you have other moisturizing factors like lactic acid or glycerine. But here the patient needs education from us because in Germany, our patients have to buy these products on their own. They get no reimbursement from the insurance company. And there the problem starts because they have already 3 up to 5 products, but mostly of them are rubbish for their skin. And we have to inform them that they should buy another one, but this leads not to very happy patients, I can tell you, because it costs a lot of money. Then we have additional to talk about skin hygiene with our patients, that it's very important to use only lukewarm water and pH neutral washing lotions with no perfume or preservatives, additionals. And there another problem starts, because especially in the winter season, as everybody knows, lukewarm water is not very welcome because the patient freezes. And if he uses washing lotions without perfumes, he wouldn't feel clean, and this is another problem. And we have to talk about the risk of injuries, so that the patient and his relatives, but also the healthcare providers, shouldn't wear long fingernails or jewelry. I think for us as healthcare providers, it's absolutely familiar, but you know, daily practice and written word are two things. Then it's very helpful to use dressings with no adhesion or only a gentle adhesion. That means silicone coated dressings and no adhesion, for example, hydrogel sheets. I don't know if they are available in every country. And don't use any constricting fixations. As you can see here, especially the elastic gauze bandages are very familiar in Germany, and they always constrict the skin and causes pain and skin damages as well. It could be helpful to use additional protective clothing like shin guards, hip protectors, long sleeves, or padding bandages. I really like this one. I don't know if you know the Yathan Second Skin arm upholstery. It's also available for other extremities. And you can use it very easily because you can clean it under tap water. It's silicone based and it avoids shear and friction very, very good. And of course, we have to identify the medications that can affect the skin of our patients, e.g. topical and systemic corticosteroids. Then we have to look at the mobility, especially on the individual risk of falling. That means we have to pay attention on the walking manners of our patients and what they wear on their foot. And I really hate these shoes. I don't know if your patients were the same. The heel says hello, he stumbles and falls, and this is not very helpful. But the patients love these shoes. I don't know why. And we have, of course, apply compression bandages properly and not like this. In Germany, I think over 90% of our healthcare providers use short stretch bandages, and they are not very familiar with the adequate techniques. And then it looks like this, and the heel says hello, and the skin gets another problem. So there we have to look carefully after. And we should inform the patients that he shouldn't wear constricting clothing like here. I really hate these nylon socks. They are not breathable and they constrict the skin as well and cause new problems, especially on the blood vessels. But they love their socks at a special age, if you know what I mean. So then we have to avoid and reduce friction and shear forces, maybe with special transfer techniques. I really like these sliding sheets or lifting devices, and we have to create a safe environment for our patients. Therefore, we need sufficient lighting, especially in the night when the patient has to get to toilet. And we have to look that there are no obstacles like loose carpets or something like this. And we have to talk about pets and possible injuries because they have sharp claws. And as you can see here, the cat was jumping on the bed and has licked on the periwound skin. And this is a real problem. So at dressing change, I think the pet should be out of the room. And this is a very huge challenge to fight with the patient because he loves his animal. And we have to look at furnishings and equipment that is used frequently by the patient so that we could pet it appropriately. So what can we do for therapy? There we have 3 steps in the treatment options. First of all, we stop the bleeding. Therefore, we use steady pressure to the skin tear, in most cases with sterile soft compresses, or as you can see here, you can use calcium alginate. The calcium has a hemostatic effort. I think most of you know this, but it's much more expensive than a sterile soft compress. So you have carefully to look which one you need. Then it's very helpful to raise the affected extremities. And in some cases, if the skin tear is very extensive or heavy bleeding, then we need immediately a specialist, for example, a surgeon, I think. The second step is to clean the wound, inclusive the periwound skin. This should be very gently and carefully. In Germany, therefore, we use physiological rinsing solutions like Ringer or natrium chloride 0.9% because these ones are reimbursed by the insurance company of the patients and can be prescribed from the physicians. But you can use, instead of them, preserved rinsing solutions, but this one the patient has to buy on his own. And then we have to remove very carefully the remaining tissue and blood. Therefore, we can use moistened sterile soft compresses and tweezers. And the third step is to reposition the skin flap. This one is very dry. So first of all, we need rehydration for it, maybe like this with a sterile moistened soft compress for up to 10 minutes. And then we can use sterile tweezers for the repositioning. If it's no longer possible, then it has to be removed surgically in time. And very important, consider always a tetanus protection because, as everyone knows, exotoxins could be released through debridement during wound cleansing. For wound treatment, it's very, very important that we don't use any adhesive products, especially with polyacrylate, because this one sticks firmly to the skin, and then you can pull off the skin cells and fragile skin when they are removed, and this causes pain and injury on the side of the patients. So instead of them, we use products with non-adhesion or gently adhesion, like silicone coating, and here they adapt very well to the skin and also seals the wound, and no skin cells and fragile skin are pulled off when they are removed. So we have a kind of atraumatic dressing change. That would be quite helpful. We have 3 types of skin tears. Type 1 is no skin loss. And this means after the repositioning, we use in Germany typical silicone coated wound contact layer as a primary wound dressing, as you can see here. These wound dressings can remain for 1 up to 2 weeks. This depends on the product and manufacturer's instructions. And it's very helpful because the wound rest will be promoted, and this is very necessary for the skin flap to heal. And for the patient, it's very important because it minimizes pain. And if there's only a little amount of exudate, then we use sterile gauzes for secondary dressing. But alternatively, you can use hydrogel sheets, as you can see here. They can remain up to 1 week and also promote a wound rest. For fixation, we use in Germany silicone-coated transparent films or elastic tubular bandages, but not the elastic gauze bandages as you have seen before. They will cause constrictions to the skin and lead to other problems. Type 2 is the partial flap loss. The wound treatment is the same as in type 1, but if the exudation is a little bit higher, then we use a superabsorbent dressing or silicone-coated fine port polyurethane foam dressing instead of the contact layer and the gauzes. And this is very helpful for daily practice. You can mark with an arrow in which direction to remove the dressing to avoid the tearing of skin flaps, or this one. Type 3, the total flap loss, is treated the same as type 2, but if there's a local wound infection, then we have to use additional wound antiseptics. We use in Germany, therefore, octinidyne or PHMB in combination with, as you can see here, a wound contact layer and gauzes. But you can use other atraumatic dressings free of active substances or germ binding dressings. I don't know if you know Cutimate Sorbact, or dressings with silver or PHMB if necessary. So at the end, what is our perspective? First of all, we have to optimize the care process and we have to create awareness. That's the hugest challenge we have to fight, as I tell you. So physicians and nurses have to plan and decide together with patients and relatives what we have to do according skin tears. Then the partner becomes a partner in therapy. Then the patient, becomes a partner in therapy. His adherence increases and also his quality of life. And altogether, we will have a better treatment, better results, fewer complications, and lower costs. That sounds very easy, but the way will be very hard and very long. But we have to go it. So here you can see the literature I've used for this presentation. And thank you very much for your attention. In Germany, we say Ende, but I know you say end, and so I X the E. Bye.
Good day and welcome to all the attendees. My name is Annika. I am a PhD student with Professor Dimitri Beekman, and I am part of the Skin Integrity Research Group at the Ghent University here in Belgium. Now, prone position ventilation has been utilized since the late 70s, and it has been proven to be an effective therapy for patients with acute respiratory distress syndrome to improve oxygenation and also to improve survival rates. We have seen now during the pandemic that there has been an increased adoption of using prone ventilation to help the patients. COVID patients very often develop ARDS-like symptoms. And when it gets to a moderate to a severe state, then prone ventilation is really effective to help the patients with survival. Unfortunately, prone positioning is not without harm. We see quite a few adverse events as listed on the screen, but of all the adverse events, your airway obstruction and pressure ulcers are the most prevalent. From a meta-analysis done already in 2014, we see that pressure ulcers account for about 34% of all your complications. We see from recent studies that most of those pressure ulcers are also actually in the facial area and also related to your medical devices. We don't have a lot of data on skin tears specifically or on moisture-associated skin damage for those patients in the prone position. But we know that skin breakdown for the patient lying in the prone position is quite a challenge. Our risk areas for skin damage are now different. Our vulnerable pressure points are now obviously on the anterior surface of the patient, as indicated with the green bubbles that you see on the screen. And of course, your medical device related pressure ulcers are everywhere under or around medical devices as the patient is now in this position. We still see moisture-induced skin damage or moisture-associated skin damage, specifically because when the patient is in the prone position, you have an increased amount of respiratory secretions coming because of gravitation. And we see a lot of moisture-associated skin damage on the chin, on the neck, and even up to the chest area. It includes also incontinence-associated dermatitis, if the patient would be incontinent, and skin tears. When you use an adhesive and it's not silicone-based, for example, then you do have a risk of skin tears. And also with the maneuvering of this patient from supine position to the prone position, it's added mechanical forces that would then increase the risk for the patient developing skin tears. Now, these two pictures were taken during the first wave of the COVID pandemic, when there wasn't necessarily a trained team. Clinicians were not used to putting the patients in the prone that often, prone position. The patient on the right, he was in the position for 16 hours, critically ill, and unfortunately during this time the pillows used to offload moved, and that consequently created unstable pressure ulcers on its chest. We see skin tears from the tape, as I have mentioned, and the moisture-associated skin damage. And when we look at incontinence-associated dermatitis, you might not necessarily see the skin damage immediately while the patient is still in prone position, and only when you turn the patient back to supine. That is why it is so important to first prophylactically protect the skin from the irritation, from the incontinence, before we see the skin even being red when we turn the patient back. Now, us as a skin integrity research group realized that it is necessary to do a comprehensive review and a gap analysis of what is actually available for the clinicians in terms of educational material, what equipment, devices to use, or what is there, what protocols are there to help the clinicians to minimize breakdown for these patients now being placed more often in prone positioning. With this gap analysis, we established an international advisory board, and the experts helped us to then develop recommendations, as it was very clear that we needed to provide the clinicians with a practice guidance document, a simple document to guide them through the processes, make some recommendations from the literature and from the experts on areas where to pay more attention to put it like that. So that's why we developed this practice guidance document. It's called Protect, Prone and Protection. And it is a real simple document, only a 3-step process of preparing the patient, repositioning the patient, what to look out for, then management and checking of the patient's skin, and at the end, a short checklist that can be used electronically or paper-based to just focus on those areas to see that nothing has been missed. It's available for free download on our website and also available in those languages. And just a few slides to point out some highlights from the literature. The efficacy of prone teams has been well established in the literature, as to have the trained, experienced personnel, if available, maybe from the operating room, using the multidisciplinary team, the physiotherapists being experts in positioning, looking after staff safety. Because of this maneuvering, obviously the clinicians also needs to utilize equipment that is also safe to them, and experts that can look at how can we prevent skin damage from happening. Positioning the patient specifically to avoid brachial plexus injury from the shoulder area. So some suggestions on that, and really to look at your devices available, your turning and positioning devices, but also being careful that when using the equipment, or maybe it's just a sliding sheet, to make sure that we don't cause skin tears for the patient. Concerning our medical device related pressure ulcers, which we have seen in the literature is a huge problem, is to really replace the endotracheal tube holder, because that hard plastic, when the patient is now in the prone position, which can cause more pressure for the patient, and rather than use ET ties or tapes. If we are using a tape, clean the skin, clip the hair, don't shave, and protect from the adhesive. Because remember, with the ET tape securement, you need better securement than what a silicone tape can provide. Therefore, it's very important to first protect the skin before we put any tape onto the skin, and rotating those tubes often. From the Prepare tab, we really looked at the text you can see in red to look at medical device related pressure ulcers, MAST, IAD pressure ulcers, and also skin tears. For skin tears, moisturizing the skin twice daily, quite important, and sometimes quite often overlooked in the critical area because of so many other things to be focusing on. So really just to remember how important it is to moisturize the skin to prevent skin tears from happening. The second and third page is really talking about more your equipment and your devices, but seeing what is available to your institution to help with the correct turning and repositioning of the patients, managing and then checking your patients. And the checklist at the end can then be used separately, maybe part of the patient's notes, to just make sure, did I look at those steps for the prepare phase, positioning phase, and the management phase of the patients. And what I want to highlight here, what we often see in clinical practice is that clinicians would sometimes wait until they see the skin is red, maybe from moisture, from the moisture we spoke about, or the incontinence, but maybe to focus on that prophylaxis, to use an alcohol-free liquid barrier from the beginning, because we know there's going to be moisture damage from the secretions, or if as soon as the patient is incontinence, fecal incontinence, then to already protect the skin before there's already irritated skin. And of course, referring to ISTAP and their guidelines available for skin tear prevention. Our research group is now going to conduct interviews with clinicians, both in Belgium and also our Swedish team, where we have a collaboration with the Skin Center for Skin Integrity from Örebro University, to understand what other educational tools are necessary for the clinicians to further prevent skin breakdown for the patients in the prone position. With that information, with the literature, again, utilizing our experts, would then be to develop an educational and training package, which we can then pilot test, first in a simulation environment and then in a real life ICU. At the end of the day, it's all about improving the quality patient care as much as we can and preventing the skin breakdown for the patients in prone position. Thank you.
Yes. What we can say, Dimitri, I think the presentations are really absolutely amazing and helpful. Thank you to all the presenters. We will go ahead and take some time for the questions now. Just a reminder, please be sure to type your questions into the question box. From our first presenter before, Ms. Karen Osi, there are some noted questions on the box before. The first question is, what are the important factors that you need to monitor for patients with infected skin tears?
Thank you, Salva. That's interesting because we see sometimes that people get inflammation and infection a little bit confused and then tend to use an antimicrobial when the skin tears inflamed rather than infected. So it's worth just revisiting those clinical signs and symptoms of infection, which are a raised temperature, the patient feeling generally unwell, increased exudate, and pain around that wound site itself. We know that the normal healing trajectory includes inflammation, so the wound will look a little bit red, but unless we've got a pyrexia there and the patient's also feeling generally unwell, there's no need really for an antimicrobial because the wound's probably inflamed.
Absolutely. In addition to that, do you think that systemic antibiotic is really necessarily in treatment of infected skin tear?
It really does depend on looking at each patient individually. If there is an infection there, then yes, we do need antibiotics, but it's not just to give antibiotics or antimicrobials for that just in case scenario. And by that, I mean, we'll give an antibiotic or we'll use an antimicrobial just in case that skin tear becomes infected. Take your wound swabs, look at whether or not the patient's feeling generally unwell, and make a decision on antimicrobials based on the facts.
I think most of the clinicians are really, looking forward to understand or to know some dressings that you can probably recommend for these kinds of infected skin tears. Do you have any suggestion for that, Karen?
If the skin tear is infected, then you can use either a medicated or a non-medicated wound dressing, depending on what your hospital or your community can get hold of. So I can't say you should use a silver dressing because it may not be on your formulary. So it's about speaking to your wound ostomy continence nurses or your tissue viability nurses, seeing which wound dressings are there, then seeing what type of infection the patient has, and then again make that informed decision. But there's lots of information out there for people to look at. So there's many documents looking at different types of medicated, non-medicated wound dressings, and then obviously the International Wound Infection Institute has their guidelines as well.
Wonderful. Now I can go ahead with some question to Ms. Kimberly in regards to the protection of peri-wound area. So we received some question with Mr. Che Mercado from UAE. His question is, do we always need to remove or debride macerated wound edges?
So that's a really great question. And certainly, we try to remove as much debris as we can, but if you try to remove too much of the macerated tissue, you can actually cause further skin damage. So I like to focus on protecting that peri-wound skin. So how can we heal the maceration? So that's when we start with some of the liquid films, such as the cyanacrylates. Sometimes, as I said in the webinar, we'll actually use stoma powder with other films on top, or we may picture frame the wounds with a hydrocolloid, but trying to protect that peri-wound is really the way to go. If there's loose debris, then we'll gently remove it. However, you don't want to be scrubbing too hard. That macerated tissue is very, very delicate. So you want to be very careful.
Thank you. We have some question also with our participant, Shelly Barnes. Her question is, how do you determine excess exudate, crusting, building up versus plugs? How can we know when to be more versus less aggressive with peri-wound dressings or cleansing?
Well, I think you always want to make sure that you're not aggressive. You always want to protect that peri-wound skin. And, if there's loose debris, it should come off relatively easily. If you're getting a plaque buildup from the maceration, then once again, you really need to focus on controlling the exudate. And we always go back to what dressing are you using and how often are you changing it? And look for a different combination, because maybe you're not using the right combination of dressings as well. So going back to the cause, it's the same way with pressure injuries or any other type of wound, right? The first thing we have to do is look, what is the cause and can we remove it? So try and remove the cause and then try and control.
Wonderful. How about what is your recommendation to protect the skin of the patient with some skin conditions like epidermolysis bullosa or bullous pemphigoid? Do you have any specific recommendations for that kind of patients?
So, the first thing we have to do is we work in combination with our dermatology colleagues to make sure that we're dealing with the underlying cause, and then it's gentle care. I'm a big believer in moisturizers when you can, applying emollients on to really protect the skin, keep the skin moisturized, and then, removing the cause when you can. Often with those conditions, unfortunately, the skin will break down very, very easily, and you're just going to have to manage that. But, looking at those different dressings that won't cause trauma, avoiding adhesives on the skin whenever possible. Those are the big things. Really look at what that patient's skin needs and avoiding those harsh adhesives.
Now, Kim, probably we can go about a little about in the scenario of critical ICU. In critical ICU, there are some cases that you really need to apply some incontinent protective, management system like Foley catheter. But there are some problems in regards to infection control. They want us to remove as much as possible in an early stage to prevent some UTI. So what can you say about this, Kim?
So can you say the question again?
What is your opinion in regards to the patient in adult critical ICU that might need some Foley catheter to avoid urine incontinence that might lead to MASD or IAD? But when it will come to infection control, they will recommend to remove it in an early stage because of the impact of UTI.
Yeah, oh, exactly. So one of the things we have to remember is that, you know, certainly catheters aren't benign, and you can cause a lot of damage by using a catheter, and they're certainly increasing the risk of infection, and especially in the ICU. And Annika's the guru on this, but you can get those medical device related injuries very easily as well. So I think, you know, it is a fine balancing act, but we have a lot of great different continence products available, containment products available on the market now. So one of the things we need to do is making sure, if we're removing the catheters, is to make sure that we're using a good barrier to protect the skin. So you have to look at what your formulary has. So, you know, find out what barriers are available in your facility and what containment products. And it's going to require frequent care and gentle care. And, you know, Dimitri is your expert on incontinence-associated dermatitis, but certainly providing that gentle care along with a barrier and frequent care is really the key.
Thank you for that, Ken. So now I will go with Stephen. So we have a question a while ago with Mr. Axel Kalu. Stephen, what is the average time to change approaches in treatment?
Yeah, well, there's not one straightforward answer to that, of course. The most important is, I think, if you have a positive evolution, we always say don't change a winning team. So I think if your treatment is going well, then of course go further with your treatment. But in our hospital, it's a bit depending on your protocol, of course. But with in our organization, we always say with a skin tear, for example, we start a treatment and we reevaluate after 1 week. Of course, if within some days you have a negative evolution, we will of course see what the problem is and we will adapt the treatment if necessary. But I think the most important is that if you have a positive evolution, you're doing it correctly, go further with it. But in general, we say once a week we will check for sure the bandage.
Thank you so much for that, Stephen. But I think we have a little minutes left, so I will just go ahead with Kirsten. So, Kirsten, we have some question with our participant, Claret Hazel Rapanut. She is asking, when it comes to skin moisturizing, I have read some publications that emollients are the most recommended to prevent skin tear. Is the water-based moisturizer won't help?
Thank you very much for this question. And we always use for dry skin products that are based on water and oil emulsions. And additionally, we use moisturizing factors, mostly urea, and not the other way, because if you use something very wet on a dry skin, it gets drier and drier. So I think we need the other one.
Thank you for that, Christine. So for our last question for today, so I can give it to Miss Annika. The question for you is, do you think that micro-shifting in repositioning patients helps to reduce skin tear?
Specifically skin tears?
Yes.
Maybe. It definitely helps with a reduction of pressure injuries, certainly, especially with your critically ill patients. With reduced micro shifts for reducing skin tears, no, not really. It's rather to look at what we have presented with the best practice recommendations and the moisturizing and so forth for protecting. But micro shifts, that's more to do with your pressure ulcer reduction.
That's good, Annika. I think I will now go back to you, Dimitri.
Thank you very much, Salvation. So thank you for moderating this session, and thank you to all the speakers who took part today in this excellent webinar. So for those attending, so don't forget that you will be able to access the video recording of this webinar on demand via the website of EWMA, and also on the website of ISTAP within this in a few days. And we hope that you will join us and other webinars in the month to come. EWMA has joined forces with some of our collaborating organizations to address compression therapy of lower legs in the 5 major European languages. We have already scheduled webinars in German, Italian, and Spanish, and we will soon announce webinars in English and French as well. Some of the topics addressed at these webinars include guideline-based care, treatment options, and practical tips for using compression therapy. On the slide as well, you can see the announcement of an initiative that ISTAP is launching next month. So we've got our first Global World Without Skin Tears Day. So that will be held on the 28th of April. So please visit the website of ISTAP, which is skintears.org, and you will find all directions and information for free registration for this, I think, unique event. You can keep yourself posted about future EWMA webinars via the EWMA newsletter, our social media, or of course our website. And there is still the possibility for registration to the conference of EWMA via the dedicated website. And finally, we would like to remind you that EWMA 2022, the conference will take place on the 23rd till the 25th of May of this year in the beautiful city of Paris. And for now, thank you again, stay safe, and have a good morning, a good afternoon, or a good evening, wherever you are. Thank you very much.